I think dismiss. Okay, whenever you're ready.
Okay. Good morning. Thank you, everybody, for logging in either today or in the future of this month for PCEP. This month's topic is management of cardiac arrest in the new AHA updates. So that information that we're going to talk about with the AHA updates comes from what was published in Circulation Magazine, November 2020. In regards to adults, some of the information that was reaffirmed is that we still want to compress deep enough, 2 inches, but not excessively, greater than 2.4 inches. We want to aim for rates of 100 to 120, and that we want to ensure our bystanders are initiating CPR with a low threshold as opposed to waiting for confirmation by our EMS folks, because of the risk of doing CPR inappropriately is a very low risk as opposed to not doing CPR when it would be indicated early on. As for double sequential defibrillation, the verdict is still that it has not been proven to be useful, and so we do not recommend that we consider double sequential defibrillation. Again, in these situations where we have refractory arrhythmias such as VFib or V-Tac, we recommend moving the defibrillator pads to hopefully get better capture and defibrillation out of the shockable rhythm. And as we talked about, I believe last year, that the evidence suggests that there may be some issues with efficacy about the IO route, and that it's preferred that we would be using a humeral IO if we are unable to get an IV access above the diaphragm. And that our protocols with Clark County, as we had discussed in a previous meeting or previous educational formats, was that IV access, preferably antecubital or above the diaphragm, if it can be done quickly, is our preferred route. And if that's unsuccessful, then IO access humeral would be preferred. If I apologize. If femoral IO is the only thing possible in an adult, then we would recommend that you move for IV access as quickly as possible. In this study, looking at humeral IO versus epi on pharmacokinetics of return of spontaneous circulation in a pig model, they determined that humeral IO delivers higher concentration of epi than IV at a 30-second interval, so there may be a survival advantage. Another topic that was brought up with the AHA update is that early epi administration in cardiac arrest is preferred. And then in non-shockable rhythms, that we would like our providers to be considering epi as soon as feasible, and that's usually within the first 5 minutes. And we'll be looking into monitoring that in our KPI reviews of cardiac arrests. As for shockable rhythms, it's reasonable to administer epi after the initial defibrillation attempts have failed, and that's usually 2 shocks and a first dose antidysrhythmic agent. And then there was some guidelines on individualized management of resuscitation. So with symptomatic bradycardia, no longer using 0.5 milligrams and moving towards 1 milligram of atropine. For opioid overdoses, the resuscitation should be the recommended resources and utilization, as opposed to trying to get Narcan on board immediately in a cardiac arrest that you suspect might be related to an opioid overdose, which is something that all of us have been practicing prior to this recommendation. And then cardiac arrest and pregnancy, goals are going to be resuscitative care, high performance CPR, Also recommend that you have uterine displacement onto the left side to prevent cable compression, and then consideration of a perimortem C-section in a term woman, so optimizing that patient to get to definitive care for a perimortem C-section, ideally within 5 minutes of cardiac arrest. Post-resuscitative care is stabilization and additional emergency activities after ROSC, which we will cover in later slides. Recognizing the importance of improving neuroprognostication. So patients that remain comatose after ROSC recommend a multimodal approach. And then in regards to recovery and survivorship, plans that address treatment, surveillance, and rehab for the survivors. Additional recommendations in regards to pediatrics is that AHA recommends an advanced airway, and they say that with an advanced airway, actually I should rephrase that, with an advanced airway, I don't think that they necessarily say that it has to be an advanced airway, any ventilation, but when you are, when you have an advanced airway, AHA recommends a reasonable target respiratory rate of 1 breath over 2 to 3 seconds, so ventilating approximately 20 to 30 breaths per minute. There's data from, I think it's Peter Hantevi had commented about regarding hyperventilation can actually be detrimental, and that specifically when a patient has an advanced airway and they're receiving positive pressure ventilation, that if you're hyperventilating, you are decreasing the coronary perfusion pressure because you're increasing the intrathoracic pressure or intratracheal pressures, which can lead to poorer outcomes. So our approach or our stance with the Clark County MPD's office is to not hyperventilate. We recommend breaths of 10 breaths per minute, enough to ventilate the patient chest rise, enough to recoil, so no hyperventilation despite the AHA current recs. And then as for cuffed endotracheal tubes, everybody, all ages, should be getting a cuffed endotracheal tube because it can improve capnography and ventilation in patients with poor pulmonary compliance if they have atelectasis or some other airway pathology. And then with an endotracheal tube that's cuffed, it can decrease the need for tube changes, trying to optimize patients that are having a cuff leak or that are having a leak because they don't have a cuff. The recommendations are to not use routine cricoid pressure with laryngoscopy and with ventilation because it can reduce the first pass success and can lead to aspiration as well as ultimately not optimal. And then in pediatrics that have suffered cardiac arrest of any setting, it's reasonable to administer initial dose of epi within the first 5 minutes from the start of compressions. If a pediatric patient has a seizure following ROSC, it's recommended to treat the clinical seizure with a benzo. And then in regards to individualized management in pediatrics, patient that you suspect has septic shock, to consider IV fluid bolus, and that can be 10 to 20 milliliters per kilogram, with frequent reassessments to ensure that you're not volume overloading, that you're not identifying evidence of pulmonary edema. So making sure that you're reassessing and titrating the consideration of additional boluses. And they had also recommended a fluid refractory shock that you've attempted bolus therapy and it's not helping this patient's hemodynamics, that you can consider epi or norepi as initial vasoactive infusion. In regards to opioid overdoses, those are pediatric patients that have inadequate ventilation or breathing, but they have a pulse, that the recommendation is to provide standard pediatric BLS and ALS care and consider administration of Narcan, either intranasal or IM. And then in regards to neonates, they strongly recommend skin-to-skin contact to be done with any healthy newborn that does not require resuscitation. And studies have shown that it can promote better breastfeeding, help with temperature regulation or temperature control, and can stabilize blood glucoses. In this particular picture, I thought the baby was a little blue, and ideally we would already have a cap on to decrease the radiation of heat from the head. So that might be a better picture of a skin-to-skin contact with our EMS folk. And then in regards to intubation for meconium in neonates, it's indicated only if there's an airway obstruction that is suspected and you've already provided positive pressure ventilation. So ventilate with a bag valve mask, and if you continue to believe that there might be an obstruction, then potentially intubate for meconium suctioning. These pictures are pretty dramatic of this condition. And then just as a reminder, this is amniotic fluid that's stained either black or greenish. It's odorless, and it consists of a lot of different components, including water, cells from the skin and the GI system, secretions from the GI system, bile, pancreatic juices. Those are just a couple of the list of the contents of meconium. And so understandably, when pediatric patients or neonates aspirate meconium, it can be very caustic to the pulmonary structures, leading to worsening respiratory failure. And in regards to access in neonates, IO access is an alternative if umbilical vein access is not feasible. We're not doing umbilical veins in the pre-hospital setting. This is more for the hospital setting if the provider, the doc, is trained to do so. So IO preferred. And they also talked about termination resuscitation in neonates. They state that newly born babies that have failed to respond to resuscitative efforts after 20 minutes of life are unlikely to have a meaningful survival or likely to survive in general. And for this reason, a time frame for decisions relating to discontinuation of resuscitation is suggested. They recommend that if this is even being approached or considered, that you have engagement with the parents and the resuscitation team prior to moving down that route. Any questions about AHA's updates, and if I missed any? I don't think so. Okay. And then the website that's on this slide is the link to the circulation article.
Jackie, one thing I might mention on the pediatric resuscitation, the respiration rate at 10, Peter Antevi does suggest that that initially you give two quick full breaths in order to get recruitment of the alveoli. So that might be, we might teach that on the initial thing for pediatric, especially young pediatric. Now, they've got epinephrine for most of your we get epinephrine early for pediatric cardiac arrests, and most of the time those are asystolic cardiac arrests anyway, or bradycardic to PEA arrest. You should treat a V-Fib arrest in pediatrics the same as you would in adults.
Those are good points. Thank you for mentioning them. All right. So going into cardiac arrest data, that's, I guess I should have mentioned CA is an abbreviation for cardiac arrest so that I don't have to type it out in multiple places in this presentation. So the risk factors for cardiac arrest to occur is going to be patients that are older in age, have a history of diabetes, maybe obese, have a family history of heart disease. Either additional risk factors include high blood pressure, high cholesterol, they're inactive or sedentary, they're a smoker, or they've had a previous episode of a sudden cardiac arrest. Any of these or a combination of these put a patient at risk for cardiac arrest. Survival has predictors for survivability from a cardiac arrest include pre-hospital ROSC, bystander early CPR, placement of an AED, and if EMS witnessed the arrest, so short downtime. And then high performance CPR. The studies have shown that CPR is the foundation of a resuscitation and a successful resuscitation. High performance CPR improves effectiveness of defibrillation to be successful, and then it also improves the effectiveness of medication treatments for distribution to the body. And that I thought might be a good idea to kind of talk about why high performance CPR is ideal. And this is just a graphic demonstration of the perfusion pressure in time in regards to CPR, in that, as you can see, in figure A, as compressions are started, you're starting to build that perfusion pressure, and it takes about 10 compressions, 10 high quality compressions to be able to get the perfusion pressure to the optimal level, which improves the perfusion of the coronaries and also improves the effectiveness of medication administration to the body or to the heart, and also improves our odds of getting a successful defibrillation. When we stop CPR, you can see that there's a drastic drop in our perfusion pressure down to almost zero again with only seconds. So it takes another 10 seconds to get back to a perfusion pressures that would be high yield, adequate. So really being mindful about doing high performance CPR, which means short pauses and no greater than 10 seconds, and being on the chest as quickly and as often as possible. So high performance CPR is a reminder or review. This is going to be minimally interrupted chest compressions, rates of 100 to 120, as we mentioned earlier, 2 to 2.4 inches, allowing for adequate chest recoil so that the decreasing intrathoracic pressures, and then they recommend rotating frequently to ensure that your compressor is not fatigued. Controlled ventilations, so only enough ventilation to allow for chest rise, pausing for 2 to 3 seconds to deliver respiratory ventilations, or asynchronous every 6 seconds. And then defibrillation, shocking on a 2-minute cycle, pre-charging your defibrillator before stopping to administer a shock, and then minimizing any peri-shock pauses. You can also consider changing out a rescuer while you are getting right after you shock. All right, and then we're going to talk about specifically cardiac arrest management, and this is going to go towards what our Clark County protocols indicate. This particular picture shows basically cardiac arrest of all causes, and then goals of treatment, care, and then if consideration of management with ROSC, but we'll go into further detail in these next slides. So in cardiac arrest initial management, to identify that the patient's unresponsive, making sure that they do not have a pulse or respirations, that they meet the criteria of being in cardiac arrest, and that if the cardiac arrest downtime is greater than 5 minutes, to start 2 minutes of CPR immediately. If the time period from what the belief that the patient's been down for is less than 5 minutes, or if there's bystander CPR, we recommend that you move towards CPR until an AED can be applied. Apply your pads and your EKG stickers. Although the defib pads should be able to identify your rhythm without that. So I guess whatever your practice is normally. Analyze and follow AED instructions, or if their paramedic is present, to have them interpret. So this is going to be a little bit BLS and ALS, although we know that most of us will have the option for ALS on scene from the initial patient contact. And then continuous CPR for 2 minutes, then rhythm analysis. Ventilations with a supraglottic airway would be appropriate and fine, giving them 100% oxygen and getting capnography on them early on as possible, but without delaying CPR and rhythm identification. Recommend IV to be TKO to keep the vein open with a balanced salt solution, preferably in a IV that's above the diaphragm. If that's not possible, then a humeral IO in adults, and in pediatrics, this should be a tibial or femoral IO. And then if you do end up having a pediatric, using a weight-based, age-appropriate system. And then for those that have hand-heavy, that could be their option, although for others it might be Broslow or a PD wheel. And then if the patient's not responding to the treatment that you have initiated, especially over a prolonged period of time, consideration of our death in the field protocol. So I think that I only bring this slide up once, so we'll talk a little bit more in depth then about it. So a patient that's in asystole upon monitoring and has not responded to 3 cycles of ACLS for asystole, so they should have approximately 3 milligrams of epi, that we can consult medical control for possible pronouncement. And then second in death in the field is that asystole upon initial monitoring, and then the paramedic's best judgment is not resuscitatable. So their end tidal is low, they're not improving. Medical control can be contacted for that. And then third option for death in the field is pulseless electrical activity. So this is a resuscitation that has occurred for at least 30 minutes, and all H's and T's have been addressed. And if the patient's not responsive, their end tidal is low, medical control can be contacted for consideration of field pronouncement. Fourth, as you can see on this list, full ACLS resuscitative efforts have been instituted and the patient's end tidal is low. And lastly, the patient who has been shown to be unresponsive to appropriate and prolonged advanced cardiac resuscitative measures, who will require continuous CPR during transport, may be determined dead in the field if consultation with medical control deems so. So in regards to an AED, if it's present, it's all the same as we just talked about in the previous slide, so I'm not going to put you through all that. Aed Defibrillation Sequence, if shock is advised, we recommend to defibrillate, continuous CPR for 2 minutes, and then analyze, unless the patient's moving or you have a large increase in end tidal CO2. Analyze, repeat CPR, analyze, defibrillate sequence until no shock is advised or arrival of ALS personnel. So this isn't a BLS situation. If ROSC is achieved, a patient gains a pulse after being shocked and treated with BLS or ALS treatment, assess vital signs, support airway and breathing, and follow our ROSC protocol. I'm going to show you our ROSC protocol at the end of this slide, because it takes me to the next one. And then other considerations: if no shock is advised and no pulse is present, we're going to presume that they do not have a shockable rhythm, more likely maybe PEA or asystole. So resume CPR, reanalyze after 2 minutes. And if the patient isn't responding to treatment, Consider death in the field, which we had talked about in the previous slide. So if ROSC is achieved and you have the ability with ALS, you may want to consider intubation, although SGA should be fine if that's what you're ventilating them with prior. Titrating oxygen to be between 94 and 96% in patients that have achieved ROSC. Monitoring end-tidal CO2 and ensuring that you're not hyperventilating them. And then if they're hypotensive, managing their hypotension. So either their systolic blood pressures are less than 90 or their MAP is less than 65. That could be IV fluids, that might be pressors. And then getting a 12 lead and preferably not initiating transport immediately, waiting approximately 10 minutes prior to initiating transport as the patient can decline and rearrest again. Any questions? All right. Asystole. Determined by paramedics, dosing is going to be 1 to 10,000, 1 milligram epi, IV or IO. If asystole persists after continuous 2-minute cycles of CPR and rhythm analysis, another additional dose of epi with the option to re-administer every 3 to 5 minutes. And in pediatric patients, you're going to be following the same adult algorithm, but the meds are going to change. So it's going to be, instead of 1 milligram, it'll be 0.01 milligram per kilogram after cardiac arrest is recognized. You should not be giving more than 1 milligram of epi to a pediatric, even if their body habitus would suggest that weight-based dosing would be greater than 1 milligram. In asystole, if the arrest is unwitnessed and there's no obvious signs of death, proceed with resuscitation. Get further information about the circumstances leading up to the cardiac arrest, as well as past medical history that might be helpful. And then also code status. Minimize interruptions to CPR when securing the airway. Ideally, SGA can be done without stopping CPR, and if you have the ability to use video laryngoscopy, you have an improved odds of intubating while doing CPR. But remembering that SGA is just fine in ventilating that patient unless you have issues with ventilating with it. And monitoring effectiveness of CPR and oxygenation, feeling for a pulse, also following end-tidal CO2, avoiding hyperoxygenation, and with ROSC is achieved, goals of SATs of 94 to 96%. In this slide, talks about H's and T's, and a lot of times I think of H's and T's for PEA, but you can also consider in any type of cardiac arrest to ensure that there's not another reason for this patient's current status that need to be addressed. So H's on the left, T's on the right, and this is specific to what our protocols guide us in for treatment. So hypovolemia, IV fluids following the shock protocol, hypoxia, oxygenate and ventilate, following airway management protocol, hydrogen ion, so excessive or they're acidotic. This might be from asphyxiation or DKA, treating with bicarb, maybe consideration for hyperventilation. And then the other H would be hypokalemia or hyperkalemia. We can address hyperkalemia in the pre-hospital setting under the hyperkalemia protocol, which would be calcium, albuterol, and bicarb. And then hypothermia, start rewarming, get off any of the cold, wet clothing if that applies. Hypoglycemia, using dextrose or glucagon if IV access is not possible. And then toxins specifically for tricyclics and Benadryl, that might look like bicarb for both, and then magnesium consideration if you have a Y complex with a TCA, suspected TCA overdose. And then as for pericardial tamponade, the definitive treatment is a pericardiocentesis, but for us in the pre-hospital setting, it's going to be considered transport. Tension pneumothorax under procedures and our protocols for needle decompression. Thrombosis, if that should be from PE. Lytics are going to be ideal for these patients or optimal, but we can consider transport in performing high Performance CPR. And then if trauma is the potential reversible cause for this patient's PEA cardiac arrest, would be HAT or hypovolemia. Oh man, can't remember what A is, but tension pneumothorax. Anyone can remind me what A is right now? Apnea? I think it's apnea. Ventilate, oxygenate, and then following the death in the field protocol. All right, in regards to PEA arrests and cardiac arrest patients, determined by our paramedics, also giving epi 1 milligram, IV or IO, and continuing with 2 minutes of high performance CPR, and then reassess with rhythm analysis. Additional epi every 3 to 5 minutes if the patient remains in PEA. And I have this bolded here because if you remember in the asystole aspect of resuscitation, or just in general in the initial management, it's TKO IV fluids, but in PEA arrest, we recommend that you address possible hypovolemia with giving IV fluid bolus up to 2 liters rapid infusion. In pediatric patients, you're going to follow the basic parameters of adult algorithm with a medication concentration adjustment of 0.01 mg per kg of epi. As soon as possible after cardiac arrest is recognized. And I believe this is Dr. Whitwer. Well, I'm going to finish this slide and I'll tell you what Dr. Whitwer and I were talking about. So repeating every 3 to 5 minutes, not to exceed the adult dose, and then consideration of 20 mLs per kilogram IV fluid bolus with constant reassessment prior to re-administration of IV fluids with the option to go up to 60 mLs per kilogram. And I think, yeah. So in regards to Dr. Whitwer, we're just saying with Fib V-Tac epi, is that right? Or are we talking about epi in, we're talking about shockable epi, or are we talking about, I think we're just talking about shockable rhythms that consider epi administration, is that right? We're not talking about non-shockable, so like asystole or PEA?
Well, we would use epinephrine in non-shockable rhythm if it's.
No, I guess I was talking about in what we were talking previously, which I'm going to say is just in shockable rhythms with epi that we're not
early
going to immediate epi administration.
Right. We're not using it early, but this is PEA, so this is a non-shockable rhythm, so we would use it. We would use it early.
Yeah. So as we're talking in this lecture, epi in non-shockable rhythms, asystole, PEA, those would be just like what you've always heard or known for epinephrine administration. And then as we go towards the next section in shockable rhythm, we'll talk a little bit about what's to come in the future with Clark County. All right, and then kind of finishing up here with PEA arrests, continuously monitor for effective CPR and oxygenation, again, avoiding hyperoxygenation if you're able to get ROSC on these patients. Treating H's and T's, I'm not going to go over each one of these again as we had talked about it in the previous. And moving forward to Fib and Pulseless V-Tac. This rhythm is identified by our paramedics, and we recommend that you defibrillate with the appropriate dosing for your manufacturer's recommendations on the monitor you have. And then right now, our recommendations is to start with 1 milligram of epi after you defibrillate, as you are doing continuous immediate CPR for 2 minutes. Looking towards the future, maybe later this summer, it may be you may want to consider, as we're talking about, we are going to move forward to this protocol change, is that you would shock 2 times and give an antiarrhythmic, such as amiodarone, before giving epi, trying not to give epi immediately after identifying a shockable rhythm and shocking it. I think I said that as clear as possible. Dr. Whitmer, would you?
Yeah, it'll be a lot easier when we write it exactly that way in the orders. But the issue is that you increase systemic vascular resistance, which is of course an advantage sometimes, but not an advantage if you already got a stressed heart. You increase your cardiac ischemia. It's probably not the best thing. It's not the best thing to do. There's good studies. It's not the best thing to do in a already ischemic, stressed heart that's gone to VFib as a result of the ischemia. So it's better to do the shock, to do good CPR, the shock. Do good CPR, the shock, give the dose of, and you can give the dose of amiodarone either before the epi or after the first shock, if that's the case. That makes more sense. And you could even, if you're having trouble drawing, getting the medication up, or there's no problem with doing CPR shock, amiodarone, CPR shock, and then do epinephrine. So epinephrine come in at least after the second shock.
So in summary, you have the option to do epi after the first shock, but we will be moving forward to a change in our protocol by the end of summer. So if you want to consider not giving epi first after shock, you have that as a consideration.
Right.
Great. Hopefully that's clearer than it seems like it might not be to me for you guys. And I'm happy to talk about this offline. And like Dr. Whitwer has mentioned, it'll be clearer when it's written out in paper hard copy format. So we're planning on, I think I was talking with Mark, I think our next update of protocol is scheduled for July. So if necessary, if it seems to be a confusional thing for people, we will update it earlier and get it published so that it's out there in June, or maybe even by the end of this month. I'll talk to Mark about that. Okay. So finishing up with our Fib Pulseless V-Tac, doing CPR, shocking appropriately, and then if continued or persistent amiodarone 300 IV or IO not to be given in a patient that is in torsades, and then if amiodarone is contraindicated, trying to remember what the contraindications would be, like allergy to, and I think is it latex out? I'll have to double check that here in a second. But if amiodarone is contraindicated, the next option would be lidocaine 1.5 milligrams per kilogram, IV or IO. And if you think that this is a multifocal white complex tachycardia, possibly related to a magnesium deficiency, you can give 2 grams of magnesium sulfate IV bolus to be diluted in 50 cc's of normal saline. Continue CPR after defibrillation, and assess the rhythm to evaluate if there is continued shockable rhythm, giving epi at that point as potentially your second line or your third line treatment, or your third indication for the antidysrhythmic. And then treatment, you're going to be immediately continuing CPR for 2 minutes after every pulse check, I guess, basically would probably be the easiest way to describe that. Defibrillating if there's a shockable rhythm, and then consideration of your additional dosing. So if you've already given 300, consideration of 150 milligrams of amiodarone. And again, if amiodarone is contraindicated, you'd be giving lidocaine if you're at that point. The dosing, though, if you've already given one dose of lidocaine at 1.5 milligrams per kilogram, I believe the second dose is 0.75 mg per kg. But if anyone knows differently, please feel free to update us in the chat or to unmute yourself. Continue CPR for 2 minutes. If they are still in a shockable rhythm, continue 2 minutes of CPR and analyze the rhythm and defibrillate. Giving another option is for epi and in transport if it's not already initiated. So essentially, looking at this, you are transporting if you've shocked them 1, 2, 3, 4 times. 3 to 4 times. Would that be reasonable, Dr. Whitwer? If they've shocked them 3 to 4 times, they are still in a shockable rhythm, to consider transport if you haven't already started.
Yeah, that's probably reasonable. That would be about 15 to 20 minutes after the first shock. So that would be probably reasonable. And of course, they should be. If they're in persistent VFib, they should be transported on a Lucas machine.
Ideally, yes.
That's your other thing to consider for transport, because if you have a 20-minute transport to the hospital and you're doing sort of intermediate CPR on the way in, you know, that patient is not going to survive that.
Absolutely. And then the last bullet point here is kind of like the generalized ROSC or death in the field or transport. And then if ROSC, no hypoxia, monitoring end-tidal CO2 and following our ROSC protocol. In pediatric patients, in regards to Fib and Pulseless V-Tac, you're going to follow the adult algorithm, but you are going to use the following dosing for defibrillation and for antidysrhythmic agents. Again, not to exceed adult dosing. So epi should be 0.01 mg per kg. Amiodarone is 5 mg per kg. May repeat 2.5 mg per kg. And then lidocaine is going to be the same adult dosing, 1.5 and 0.75 for your subsequent dose. Sodium bicarb is going to be the same for adults and pediatrics, 1 milliequivalent per kilogram. But if the child is less than 10 kilograms, you're going to dilute the bicarb by half with normal saline.
And we'll pay extra money for anybody who brings us evidence that you've actually had a kid less than 10 kilograms, or probably less than 30 kilograms who's in VFib.
Big money. Big money. All right. And then notes and precautions under our protocol for shockable rhythm is that the airway should be addressed with minimal interruptions to CPR. Ventilation rates should be 8 to 10. Our recommendations for all comers, adults and pediatrics, is going to be approximately 10 respirations per minute, despite whatever range of age. And if the patient remains in persistent shockable rhythm greater than 3 shocks, reposition the defibrillation pads apologize for the typo in that defib, in a arrangement that is different than what you start off with. So if you've already done anterior posterior, trying a different different placement. And then sodium bicarb is not recommended in routine cardiac arrest sequence, only if you think that this is potentially a tricyclic overdose, or the patient's hyperkalemic, or the patient has been down for a prolonged period of time. All right, you guys did high performance CPR. You had optimal conditions for survivability. You achieved ROSC. So optimize ventilation and oxygenation, intubate as needed. And this was kind of covered already in a slide previously, but we're okay on time. So it's not bad to recover or revisit this. So titrate oxygen to the lowest level to be able to attain an SpO2 of 94 to 96%. And then end-tidal CO2 should be optimized for a range of 35 to 40. Do not hyperventilate. And if the patient's hypotensive, either systolic less than 90 or MAP less than 65, follow the shock protocol, get a 12 lead EKG, and transport all patients with ROS to a hospital with interventional capability. As it stands now, that would be Peace Health, correct?
Correct.
Okay. And then if patients have ROSC, observe briefly to ensure sustained stability prior to transport, usually 5 to 10 minutes, as the patient is likely to rearrest or have further hemodynamic instability initially right after achieving ROSC. All right. Any questions before moving into the Washington CARES data for us from last year?
Hi, this is Sam Harrison. I had a question. Can you hear me?
Yes.
So just going back, we just got done talking about after if you got somebody in VFib and you've shocked them 4 times, you should probably think about transporting. But also back in the death in the field protocol, it says, you know, the need for continuous CPR during transport is one of the death in the field criteria. So I guess which way do you want us to lean, or what's the flavor of the month on that one?
Sam, that's why I mentioned that that ideally you would have a Lucas there.
Yeah, and I would add, which I'm certain Dr. Whitwer has talked about before previously, and will likely agree that shockable rhythm that is refractory to everything you're doing, we're concerned that this is a patient that has a lesion in their coronaries. That's why they're in this shockable rhythm. And so there's a potential that if we can either get ROSC and get them to the cath lab to stent or deal with that lesion. In some hospitals where I've came from, they've kept them on the Lucas and taken them to the cath lab for intervention, but that's not kind of where we are here at Peace Health. But that the reason why they're in that shockable rhythm is because there is a treatment that might actually get them out of that sustained shockable rhythm. And that's the difference in general with the death in the field, saying that we're not really wanting to transport people that we're doing continuous CPR. That's because we don't really have any different outcomes that at the hospital that might ameliorate their problem. In this situation, that they could have an MI or a STEMI or something along those lines that we could address in a time-sensitive manner. Is that accurate?
Yes, that's why probably the best advice if you do have a Lucas and you think that the patient has a history of the patient was the witness to arrest, et cetera, and you have all of that data, and you might consider transport to the hospital, although frankly right now there's not much different that the hospital would do.
We can, I believe, give labetalol, and occasionally that has been successful in getting people out of sustained refractory.
Yes, and we're considering looking at that as a potential for. I'm not sure that labetalol is the best one. I would say that probably one of the even quicker beta blockers might be the best thing. My mind is not functioning on that one right now, but Any rate, those are some of the potential. So there are a couple of things that the hospital can do, but really, you really have to consider, if you only have a 5-minute transport to the hospital, well, sure. But if you have, if you're coming from, mid county or far out county, and you're going to do, you can't do adequate manual CPR all the way to the hospital. So you really need a Lucas device at that point. And so that's going to be one of your considerations. And the easy thing is, not easy thing, but thing is to contact medical control and get the doc on the line to help you decide how you're going to do this one.
Yeah, and I think maybe Esmawal, was that the other one you were thinking?
Yes.
Yeah. And I would say my experience in speaking with the other ER docs that are taking medical control calls is that they're, especially our younger colleagues, that they are very hesitant to call a shockable rhythm, even if you've been there for a bit.
But at the same time, they need to understand that transporting a patient without a Lucas is not very, very functional.
Absolutely. So I would say for us that are calling medical control and you are calling for a field pronouncement in a shockable rhythm, to point out or to make a comment that do not have a Lucas. We are approximately 40 minutes, 30 minutes, 20 minutes from you.
Right.
That's a great question.
Jackie.
Thank you. Yes, go ahead.
Jackie, it's Marty Bell. I took a call on a shift a couple of weeks ago, I think it was, for a refractory VFib case, and somebody in the audience may have been on that run, but they asked my advice whether to transport or not, and I, kind of debating about it, but I did recommend it finally, and the patient was defibrillated, had the double sequential defibrillation in the ED, and got out of it into ROSC. I don't know how the patient did ultimately, but that was.
Yeah, I don't believe that patient survived.
Okay. Yeah, that was. I can't remember if they had a Lucas device though, as far as the transport team.
No, I can't remember either. And the interesting thing about that is that there's absolutely no. Now, one thing I have not heard back from the crew on that one as to whether or not they changed the defibrillatory pads in the field. Because I believe that patient was on a Lucas device and I thought, well, maybe if he's on a Lucas device, they really weren't able to change, because if they put the AP there to start with, maybe they couldn't change it.
To the lateral and anterior, yeah, it's possible.
Yeah.
And so I haven't heard back from it, but see, that's kind of that's kind of where we need to practice next month for our cardiac arrest skill sessions, is that one of the things is to practice using with the Lucas device, to practice placing the pads and then maybe changing the pads, or maybe in VFib we should put 2 sets of pads on to start with.
Yeah, that's a possibility. That's a good point. And like I said, I find that especially what we consider young people to be in refractory shockable rhythm, that it could be a 50-50 chance that you'll be asked to transport, or even higher.
Right. And I'm okay with shockable rhythm transporting, as long as you have a Lucas device, or you have extremely short transport time. Otherwise, it just makes no sense to me at all.
Yeah. Thank you, Dr. Bell, for your experience. All right, any other questions before we move to our cardiac arrest data from last year? All right. Dr. Whitmer, let me see if I can get out of this real quick, and I'll just tell me next slide when you're ready. All right. So this is probably more for me than for anybody else on this call, to remind us where we are in Washington. All right, go ahead.
All right. So our data for this last year, we had 292 cardiac arrests in 2020. And the age group is about the same as it was last time. Twice as many males as females. I'm not sure when dealing with our equity issues, I'm not sure that race is actually makes any sense, because I noticed that of that, almost all of these, I mean, 2/3 of these are listed as being white, and then unknown of 76. Now, which means to me that that people don't put down a race as a general rule, or default to white or default to unknown. So location of arrest, most everything happens at home, 79%. Nursing homes, so, although they're sometimes the most confounding, is 9%, and public settings is more than that, 12%. Next slide. Okay, and our bystander witness, 37% of our things were bystander witnessed, 12% witnessed by a 911 responder, and generally those are, you all know those cases that you called to the scene for chest pain or whatever else, and the patient arrests in front of you. So unwitnessed, unfortunately, still 50%. That's going to come up after a little bit here too. Who initiates CPR? Bystanders, 61%. First responders, 15%. Emergency EMS services, almost 24%. So bystander, and they do include bystander if the bystander was instructed to do CPR by the dispatch. Was an AED applied prior? Yes, 18% of the time, no. So, and AED is generally that AEDs when applied is generally due to police or to public access defibrillator, or to defibrillator that's like in a sports complex. We did have one where it was applied by a retired firefighter who came across the street from his own home with his AED. We don't even want to ask where it came from, but it worked. And then, but most of the time, your first defibrillation well, it wasn't even marked, I guess. So first arrest, here's the important thing. First arrest rhythm, 23% VFib, V-Tac, asystole 52%, that's not a good sign, and PEA 22%. Next. And then the hospital, well, was there sustained ROSC? And sustained ROSC is defined as sustained in the field and or sustained at the during transport and or ROSC at the time they hit the emergency department. So sustained, basically, you could say it lasts throughout the entire. It could have been gotten in the rig on en route, but at any rate, they have it when they get to the ED. 35% had sustained ROSC. Hypothermic care provided in the field, no, we don't do that anymore. Pre-hospital, that's still a field though. Pre-hospital outcome, 50% are pronounced in the field. That's higher than usual. 5% are pronounced in the ED, and ongoing resuscitation, 44%. Overall survival, here's our overall survival to hospital admission is 28%. Overall survival to hospital discharge is 14%. And you might think, oh my God, we've dropped, because last year was 18% and change. And then our Utstein survival, remember Utstein survival is whether or not you have, whether it's a witnessed arrest, first on arrival of EMS, it's a shockable rhythm, and you have it's basically the two main criteria. And then bystander survival is if the bystander is doing CPR. Now, interesting enough, and it must be a sort of an interesting problem with statistics. Utstein survival, those are the ones you would think would be the most likely to have. That's almost 42%. And Utstein bystander survival is barely 42%. It just a little bit above that. So it doesn't seem to be that much of an advantage. And last year, when I looked at it last year, Utstein bystander survival was less than the Utstein survival rate. But this is a nice thing. So it's an advantage that if the bystanders start to do CPR, that is an advantage. Utstein survival of 42% compared to last year was about 48%. So, but everybody in the state of Washington is less than it was less of this. We're above state of Washington survival. And several places were significantly lower. I think this is a reflection of COVID and the fact that possibly people aren't calling early enough. They're ignoring symptoms, and so when you get there, they're actually in asystole, and we end up calling it, or they've been down longer, even though they're in VFib. They've been down longer than expected, or they've been ignoring some major cardiac symptoms. And also possibly because it takes us a little bit longer to get in to the house with the full, or the facility with full PPE on the full team. That's the only way I can explain what happened. And across the country, the survival rate has dropped to around 8.79 to 9%. So that's significantly down too. Next. So this gives a picture of what our survival rate is. You can see our survival rate right now is about the same as it was in 2014, although we have higher numbers. We were surprised that we had this number of, that's a lot more cardiac arrests this year. And that's true for the entire state as well, is that our cardiac arrests have increased by about 15% for this year. Once again, I think an effect of COVID. Now, I've only had positive COVID tests on 3 cardiac arrest victims last year. So it's not like they were going down from COVID with their cardiac arrest, but it's just that we didn't. Now, unfortunately, if we're not transporting them, they generally didn't get tested for COVID. So we just have to extrapolate. Next slide. Oh, this is the Utstein survival. So you see, we're not terribly off where we were in 2019, and better than 2018. So and 2016. So not a terrible thing. Next.
And that is it.
And actually, I should have pulled out there's some drill downs in the in material I presented to the chiefs the other day, which really shows that, I mean, basically the survival rate from asystole has not changed probably since I began in medicine, which is a long time ago. And I mean, still, our survival rate from initial asystole, and by survival I mean all told, and we did get ROSC on some asystoles, sustained ROC. They were transported, and of the 20 or so asystolic patients who had sustained ROSC and were admitted to the hospital, so they survived the ED as well, then only one of those patients was discharged alive. And overall, we have like 1% survival from asystole, so 1 out of 100. And I think that person had surprisingly a reasonable neurologic recovery as well. Now, PEA is much better, but I mean, not that much better. PEA, if you get sustained early sustained ROSC, you would probably have somewhere in the neighborhood of 7 to 10% survival. But that sort of puts it, the longer you do, it's kind of a confounding thing, because just like in Portland with PEA, we say, hey, work it for around 30 minutes before you're going to call it. Well, and as long as you're doing all the H's and T's and all that stuff, that's okay. If you have a Lucas machine on, that's even better. But there still are points where we're going to have to call it all. Although there are some of my colleagues, at least in the Portland system, that insist that the longer that you have like 8% survival for every additional 2 to 3 minutes of high quality CPR and treatment in the field. But frankly, I don't see that. I don't see hardly anybody who gets ROSC after 6 doses of epinephrine and other medications. Almost nobody survives. Many have survived to be admitted to the hospital, to the ICU, and on temperature, controlled temperature management, et cetera, and almost none of them also survive. So the longer they're in the PEA, the less likely they're going to have neurologic recovery. You're going to get you can pour epinephrine into people, and you can get some sort of life back. You can get hearts back, but we don't get neurologic recovery back. And that's what ultimately they all die of, is anoxic brain syndrome. So that's a pessimistic look at things, but
But important to recognize.
if you can get early ROSC in the PEA patients, especially people that have wide complex PEA. I mean, think about the acidosis, think about hyperkalemia, think about the things you can treat, and that actually, if you get early return, they have a marked improvement in their survival and their neurologic recovery.
There were a couple things in the chat. So contraindication to amiodarone is a high degree heart block prior to arrest if they don't already have a pacemaker. And then another contraindication to amiodarone would be prolonged QTC or QT. Yeah, QTC.
Well, and it would say, unless you're really good at trying to read prolonged QTC in the field, or if if you can read, how do you know you're going to have prolonged QTC if they're in VFib at the time? So look at their medication list. If they're taking amiodarone, it's not working, and you're probably doing too much. And that's too much amiodarone gives you prolonged QT.
Yeah.
That's why I don't recommend it if you already have a patient in prolonged QT, i.e. or SODS.
Mm-hmm.
So that would be the simple, unless the patient can tell you, or the patient's family can tell you they had a problem with amiodarone. One of the other things, if you know that they're already on a prolonged QT drug, such as a tricyclic, such as Pronesto, such as quinidine, or Sotalol, they're all oral medications that people can take.
And that might be another additional consideration, is that your patient arrested after you gave a med that might be a QTC prolonging med, if that would be Haldol, if that would be Zofran, if that would be droperidol as we move forward with that. So another consideration is that your arrest might be QTC related based off of what was just administered.
Yeah, I don't want to scare people about that, because that's, that we don't carry enough Haldol or droperidol or anything to actually affect. I mean, the reason that droperidol got black box in the first place was that very sick people in ICUs were on massive doses for some reason of droperidol, along with other stuff.
I agree, it's probably unlikely, but I mentioned it only after a recent experience in a 23-year-old that just got 5 of Haldol that had a V-Tac from that. So just FYI that it's probably very unlikely, but.
What were they on?
Huh?
What were they on also?
Marijuana, hyperemesis cannabinoid.
Okay, I'm just curious, because it's hard to imagine that 5 milligrams of Haldol would have done anything to. So unless he had a prolonged QT syndrome to start with.
Yeah, which I think is probably the case. But
Yeah.
But just be aware that maybe, if you're talking about your H's and T's and things that you want to be cognizant about, and you are looking for reasons not to give amiodarone, make sure that you are addressing all the possibilities. If you don't have if you're talking about QTC prolongation being a contraindication.
Sure.
Does anyone else have any other questions, comments, clarification, anything like that? If that's Oh, go ahead. I think I heard someone stirring. If there's no questions at this time, you're welcome to reach out to me in person or by email or cell phone. But thank you guys for your attention. Thank you, Dr. Whitwer, for clarifying and adding additional information to this topic.
Thank you.
Greg, well, thanks, Dr. Gadbois.
Thank you, guys. All right. Have a great Tuesday.